Good afternoon. This is the first session of Mycobacterium tuberculosis. So the specific learning objectives we'll be dealing with. You have to know how to describe the epidemiology of tuberculosis, including its incidence, and discuss the microbiology of TB, modes of transmission, and enumerate the diagnostic methods of tuberculosis and its drug resistance, how to diagnose drug resistance, and the treatment part we'll be dealing with in the next session. So this bacillus has existed from the very dawn of civilization. Records of TB in mummies were found in Egypt as far as 5,000 years ago. Extrapulmonary tuberculosis was also known since antiquity. The Pott's disease has been described in paintings and statues of ancient Egyptians. It was Jean Antoine Villemin who demonstrated that the disease was contagious. He did an experiment in which the tuberculous matter from human cadavers was injected into the laboratory rabbits. This is a very important person in the history of tuberculosis, Robert Koch. He was the person in 1882 who isolated the mammalian tubercle bacilli. He proved its causative role in TB by satisfying the Koch's postulate. In March 24, you did note the date, March 24, 1882, he made his result public at the Physiological Society of Berlin. This day, since 1982, is known as World Tuberculosis Day. On April 10th, 1882, he presented an article in which he demonstrated that bacterium was the single cause of tuberculosis in all of its forms. So this day, since 1982, is known and celebrated as World Tuberculosis Day. He was awarded Nobel Prize for this discovery in 1905. Now about the epidemiology, you have to know about the world epidemiology and the epidemiology of tuberculosis in India. The 1/3 of the world population is infected with tuberculosis, of which the only 5 to 10% develop disease. So around 1/3 of the world population is infected with TB, and around only 5 to 10% of this infected person develop disease or tuberculosis. An infectious TB case infect 10 to 15% per year. Now about India, it is one of the highest TB burden country. Around 26% of the estimated global incidence is from India. More than 40% of population infected with TB is in India. So the comparison of the world cases of TB and India incidence in India. So 10 million cases had TB in 2019 statistics. In India, around 2.69 million cases are there. Around 1.2 million deaths in the world in HIV negative, and 440,000 deaths in HIV negative in India. So deaths in HIV positive is around 208,000 in the world, while in India it's around 9,700 deaths in HIV positive patients. The drug resistant cases, it's seen in around 3.3% of new cases and 18% of retreatment cases in the whole world, while in India it's around 2.84% in new cases and 12% of previously treated TB cases. Now into the microbiology of the TB proper. About the bacilli. The bacilli belong to the genus Mycobacterium of the family Mycobacteriaceae, order Actinomycetales, and class Schizomycetales. It causes tuberculosis in man and is occasionally found in animals, notably pigs, cattle, and monkeys. Multiplication outside the host does not occur naturally. Now it is an obligate aerobe that it needs oxygen for its growth. That's why most of the TB cases of Mycobacterium tuberculosis complex are always found in the upper lobes of the lung. The bacterium is a facultative intracellular parasite, especially inside the macrophages. And the generation time, it's around 15 to 20 hours. It has got a slow generation time. That's why it has got a virulence. It contributes to the bacterial virulence. The morphology, it's a non-motile, non-sporing, rod-shaped bacteria. They are slender, straight or slightly curved rods, and its length is around 1.4 micrometers and the width is around 0.3 to 0.6 micrometers. It is heat resistant, that is, it is being killed in 60 degrees Celsius in 15 to 20 minutes. That's why we don't ask the patients to keep the sputum in the sunlight. Okay, you should protect it from the direct sunlight. Survival is influenced by the material in which the bacteria are present. The cultures may be killed by direct exposure to sunlight in 2 hours, but bacilli in sputum may remain alive for 20 to 30 hours. So culture, if exposed to direct sunlight, may be killed in 2 hours. The bacilli in droplet nuclei, that is in the environment, may retain viability for 8 to 10 days in suitable conditions. That is, at room temperature, the cultures may be viable for 6 to 8 months, but may be stored up to 2 years in minus 20 degrees. So direct sunlight exposure may kill the bacteria faster. Now the resistance to the chemicals. So chemicals, most of the chemicals, the bacilli are relatively resistant. How to kill the bacilli on the surfaces or in the infected material? They are sensitive to formaldehyde and glutaraldehyde. They are destroyed by tincture of iodine in 5 minutes and 80% ethanol in 2 to 10 minutes. So ethanol is a suitable disinfectant for skins, gloves and thermometers. Now the modes of transmission, whatever be the form of tuberculosis, the main mode of transmission is through inhalation. Now the diagnostic method, this is very important, how to diagnose the TB. Now diagnostic method, we will be dealing mainly with the microscopy, culture and the newer molecular methods. So the first one is the age-old microscopy using Seal-Nielsen staining. The most widely used till now employs basic fusion para-rosanilin dye in phenol. This is the staining with the Seal-Nielsen staining technique. You can see the pink rods against the blue background. This is also another slide, pink rods against the blue background. The next one is the quinone staining, almost similar to the Seal-Nielsen staining. The acid-fast staining very similar to Seal-Nielsen, but here it is called as cold staining, where here there is no heating. There is no heating and uses high concentration of the phenol. Now the TB bacilli can also be stained with fluorescent technique, that is carbol oramin stain is used. On exposure to the UV light, oramin, if yellow fluorescent dye, the fluorescence in the visible region. So the bacilli will look bright yellow against the dark background under fluorescent microscopy, that is yellow bacilli against black background. This is another picture. Evidence suggests that staining with the oramin gives a higher yield, that sensitivity is more. That is, you can see the bacilli, even if it is only 1 or 2 bacilli, you can pick out the bacilli more. Better method for tissue specimen. Now Gram stain, when you stain the Mycobacterium with Gram stain, it's weakly Gram positive. A few words about the cell wall structure before going on to the culture. The cell wall structure, the cell wall is a very important structure of Mycobacterium tuberculosis. It's a major determinant of the virulence of the bacterium. It is the target of very many antitubercular drugs like INH, pyrazinamide and ethambutol. It mainly contains peptidoglycans and other complex lipids. Over 60% of the Mycobacterium cell wall is a lipid. It is a major target for very many antitubercular drugs. The lipid fraction of MTB cell wall consists of three major components: mycolic acid, cod factor and Wax-D. You have to know that mycolic acid, cod factor and the Wax-D. This is the cell wall. You can see the mycolic acid, different mycolic acids. You have polypeptides, peptidoglycan layer also. Now about the culture, I told you it has got a slow generation time, 15 to 20 hours. It grows very slowly and the colonies appears in about 2 weeks. It may take up to 8 weeks, 6 to 8 weeks. The optimum temperature is 37 degrees Celsius and the growth does not occur below 25 degrees Celsius or above 40 degrees Celsius. The optimum pH is around 6.4 to 7. It's an obligate aerobe and the atypical mycobacteria on primary solution becoming aerobic on subculture. The typical mycobacterium grows luxuriantly. So the culture media, the growth is called as eugonic. And the atypical mycobacterium, the culture media, it grows sparsely. So it is known as dysgonic. So this is the eugonic rough colonies of Mycobacterium tuberculosis. And the right one is the dysgonic culture of atypical mycobacterium, which is more smoother. So very many biochemical reaction which is not used very frequently nowadays to differentiate between the atypical and typical mycobacteria. The conventional media, the conventional culture media is the LJ media. LJ media is the solid conventional media, that is very many other solid medias are there, blood media, serum media and potato agars. The commonest conventional media is the Lowenstein-Jensen media, which is recommended by the International Union Against Tuberculosis. It consists of coagulated hen's egg, mineral salt solution, asparagine and malachite green, which gives the color to the media. This is the color of the media, you have to know this. The typical mycobacterium, as I already told, is a eugonic culture. It grows very well. It causes a rough and buff colonies. It's a rough colonies, raised irregular colonies with a wrinkled surface. They are creamy white, becoming yellowish or buff colored on further incubation. They are tenacious, not easily emulsified, cannot be broken off very fast. While the atypical colonies, they are flat, smooth, moist and break up easily. That is the difference. Rough and buff colony, yellowish colony doesn't break off faster. The typical bacteria, atypical bacteria breaks up easily while you touch it. This is the typical mycobacteria. Now very many liquid medias are there. Liquid media, Middlebrooks media, Dubos media, then Bactec. Bactec is the newer methods. Bactec 460 TB system. This is the currently used liquid media. Here the disadvantage of the conventional media was it takes longer duration to give a negative report. In this Bactec system, it takes only around 2 weeks to give a negative report. The media used in the Bactec system contains radio-labeled palmitate as a sole carbon source. When the tuberculosis bacilli multiplies, it breaks down the palmitate and liberates the radio-labeled carbon dioxide, which is measured radiometrically. It takes around 9 to 16, around 2 weeks, whereas in conventional media, it takes around 4 to 6 weeks. Now other conventional newer methods are the MGIT system. This is the most commonly used nowadays liquid media. This is the Bactec MGIT system. Now about the molecular methods, which is the current thing in the scenario, that is CBNAT and the line probe are the two molecular methods which are used to detect mycobacteria. The few words about the nucleic acid amplification test, that is it can be cartridge based or TrueNAT. These are the two machines where you can do the NAT. NAT is nucleic acid amplification test. Here you detect the Mycobacterium tuberculosis complex. Also you can detect the resistance if present or not to rifampicin. Okay. So it is a PCR based test. It is also called as CBNAT, or the other machine is TrueNAT, cartridge based nucleic acid amplification test. You detect the TB bacilli and also the rifampicin resistance. Sensitive than the smear microscopy. Also the advantage is the turnaround time is around only 2 hours. Not useful for assessing response to treatment. That is, if you are following up the patient taking treatment, don't do CBNAT, you go for microscopy. About the line probe assay, line probe assay is also a molecular method. You can detect the MTB bacilli, also the resistant to INH and rifampicin in the first line probe assay. You have second line probe assays also. Now I will be mentioning you about the algorithm in our current program for the pulmonary TB and the extrapulmonary TB. This is the first diagnostic algorithm in the pulmonary TB, the new guidelines. When you get a TB suspect, the patients with presumptive TB patients with TB symptoms, pulmonary TB symptoms, you subject the patient to smear examination and X-ray, and if you find a smear positive patient with or without X-ray suggestive of TB, you subject the patient to CBNAT and LPA. Current guidelines say about LPA also. If you detect rifampicin resistant, consider him or her as drug resistant TB and refer for treatment for drug resistant TB. If you don't detect rifampicin resistant, consider him or her as drug sensitive TB and refer for treatment for drug sensitive TB. So if the smear is negative, still you suspect you have an X-ray suggestive of TB, you can subject him to CBNAT, and if you get a positive result, you go along with it. If you get a negative result in CBNAT also, then still the clinical suspicion is high, you can refer him to specialist and you can still give the treatment as clinically diagnosed tuberculosis. Here you can see the patient living with HIV. These patients and the pediatric patient, you have to do an upfront CBNAT. That is, you don't subject him to AFB smear, you directly go for CBNAT and look at the result. Now next, for extrapulmonary TB, whenever you get a presumptive extrapulmonary TB patient, whatever be the site, lymph node, spine, bone, etc., if there is an appropriate specimen from the site, here in this situation, you subject the patient for CBNAT. If CBNAT is not available, you can go for liquid culture if it's available, and if the culture is positive, you can, or the CBNAT is positive, you can consider him as microbiologically confirmed TB and give the treatment according to the drug sensitivity in the CBNAT or the culture. But if it's not, these two are not available and you have high suspicion or high index of suspicion for TB, you can still give treatment as clinically diagnosed after referring him to a specialist. So with this I hope the specific learning objectives is clear to you with the competency attained. Thank you.